Our topic today is Kawasaki disease, and we will have Dr. Portman speak on that. Dr. Michael Portman is the Director of Research in the Division of Cardiology at Seattle Children's and Professor in the Department of Pediatrics at the University of Washington. He is attending physician at Seattle Children's Heart Center and the Cardiology Clinic at Providence Everett Medical Center. Dr. Portman's research activities include pharmacological clinical trials, basic science research projects focused on cardiac metabolism in animal models, and mentoring future clinical researchers. He's an editorial board member of the American Journal of Physiology, Heart and Circulatory Physiology, and co-investigator for a grant on cardiovascular research training. He also leads the Portman Research Group, which is developing innovative ways to protect children's hearts from damage related to heart surgery and is improving how the medical community understands and treats Kawasaki's disease. So let's welcome Dr. Portman.
Thank you. It's a great pleasure to be here. My wife's a nurse, so she told me to remind everyone that she's a nurse. So, we have here at Seattle Children's a very active program in Kawasaki disease. We see about 50 new patients a year. We have a specific Kawasaki disease clinic, which I see patients, and my colleague, Dr. Erin Olson, sees patients pretty much for their follow-up after they're discharged from the hospital. And we have a very active research program, and as I go through, you can see all certain aspects of research that we do. Even today, we're involved in a clinical trial, and we enrolled our first patient in a trial I'll tell you a little bit about later. Let's start with about Kawasaki disease. Everyone thinks about the motorcycle, and the kids certainly do when they hear what kind of disease they have, which is why I put it on this slide. So Kawasaki disease is an acute systemic vasculitis. So it affects all arteries, but it seems to have a predilection, and we know it has an attack on the coronary arteries where most of the inflammation occurs. So most of the kids do not get severe inflammation, but for those that do, there could be dilation of the coronary arteries with aneurysm formation, and the most feared complications are development of a clot in those aneurysms, which can subsequently cause stenosis, or later on, even many years later, there can be remodeling of the coronary arteries that cause stenosis. And the most feared symptom is a myocardial infarction, which is rare, and as far as I know, over the past 10 years at Children's, we've only had one child with an infarction, but it's still pretty nasty if you're a 3-year-old having an MI. We really don't know the cause. We think that there's some sort of environmental trigger. It could be infectious, and it stimulates an inflammatory response, an auto-inflammatory response in the patient's body, so that the patient's body itself attacks their own arteries. In the United States, it's really hard to get an estimate of the total number of new cases per year. We think that it's somewhere around 7,000 is what I would estimate. And of those, with our rate of severe heart disease from that, it should be about 400 cases a year. So although it's an uncommon disease, most centers do see fairly severe cases, most major pediatric centers. In Seattle, the rate for severe disease, about 7% of our patients develop coronary artery aneurysms, even though they get appropriate treatment for Kawasaki disease. And we've published that in the Open Heart Journal. That was a series, I think we had about 60 or 70 patients with aneurysms in our entire series. So most people are aware that Kawasaki disease is named that because of Dr. Kawasaki, who described it in the 1960s. And the reason that he most likely discovered it and described it for the first time was because the incidence in Asia, and particularly Japan, is substantially higher than the incidence in the United States. So in Japan, the incidence is 250 to 300 per 100,000 children, while in the United States, it's somewhere around 20 per 100,000 children. So it's more than 10 times the rate in Japan, and in other Asian countries like Taiwan, Korea, Vietnam than it is in the United States. Nevertheless, at Seattle Children's, 70% of the children that we admit are not Asian. So that's something to think about. So even if a child is not Asian, that you do need to think about Kawasaki disease if they have the appropriate symptoms. So how do we diagnose Kawasaki disease? So we have set clinical criteria, and these are by American Heart Association guidelines. The most important criteria is that you have a fever, the child has a fever, and in Fahrenheit, that's 100.4, centigrade 38, and it's for 4 or 5 days from the onset of fever. So sometimes we have patients who come in and they had fever about 6 or 7 days ago for a couple days, no fever for a day or two, and then fever for like 3 or 4 more days. So it's not how many individual days of fever, but from fever onset. So if you have onset of fever, maybe 1 or 2 days, no fever, and then fever starts again, that's the total that you don't count each individual day. Then in addition to the fever, you need 4 of 5 of the following criteria. There's a non-purulent conjunctivitis, and I'll show everybody what this looks like. There's cervical lymphadenopathy, which is greater than 1.5 centimeters, and that's the least common symptom, but it does occur. There's this rash it's almost any type of rash except a bullous or blistering rash. There's what we call mucositis of the mouth, where you get cracked lips, strawberry tongue, and then there's extremity changes. When they come in with acute Kawasaki disease, over the first week or so, it's swelling of the feet or the hands with redness. Later on, after day 7, because it's kind of like having a sunburn, the skin starts to peel. So that could be an important sign. But importantly, you do not have to have all these symptoms at the same time. Some of the symptoms, particularly the rash and the lymphadenopathy, they can come and go. So if a parent comes in and says, well, 2 or 3 days ago, my child's eyes were red, that counts as one of the symptoms. If they said, well, my child's neck was swollen, that counts as one of the symptoms, even though when they're being examined in the emergency room, they may not have those symptoms at the present time. The other thing that's important is that you need to exclude other diagnoses, because obviously these symptoms can occur with other childhood illnesses. And there is often confusion with that, because you can have other illnesses, even respiratory infections, that are concurrent with Kawasaki disease. So the presence of those respiratory illnesses in particular does not, or even a strep throat does not exclude Kawasaki disease. Okay. So everyone thinks of Kawasaki disease as something that happens in very small children. And most of the statistics say, okay, like those incidence statistics, that's what occurs in children less than 5 years of age. So what the problem with that is, if children come in and they're outside that age range, the physicians or the people trying to make the diagnosis are not thinking about Kawasaki disease. So I would just say, forget the age qualifier, that any child who comes in, even adolescent age, with the fever and the symptoms, you need to think about Kawasaki disease. You need to, in fact, have a very high suspicion for Kawasaki disease in the older children, because when they get Kawasaki disease, it's often even more severe than occurs in the younger children. So because of this misconception that it can't occur in older children, they are often misdiagnosed, or the diagnosis occurs late and they do not get appropriate and timely treatment. So I just want to emphasize that point, that any child of any age, and let's say even up to 18, can have Kawasaki disease. So here's some of the examples of what Kawasaki disease looks like. These are some of the more extreme examples. So here you have a child, and he's got very red eyes. You can see his lips are very red. He has the red cheeks. So right there, I've lost my mouse. I think right there you can see. So here's 1 symptom, 2, 3. So just looking at his face, you've got 3 of the criteria for Kawasaki disease. Here's what the conjunctivitis looks like, and you see there's redness, but It's not the same thing as red eye, because kids with red eye, number one, they might have one eye. This is bilateral, so both eyes are involved. There's a redness that are in the white part of the eye, but there's no pussy drainage. So if there's pussy drainage, it's very unlikely to be Kawasaki disease. Here's what the strawberry tongue looks like. I think this is pretty clear. This can also occur with strep throat. But also in this picture, what you don't get with strep throat is cracking of the lips like that. And you can see this very severe cracking that we call mucositis. And these are different examples of the rash. Remember I said it's what we call a polymorphous rash, which means it could look like almost anything. And in this one case, in this case here, you could see it's in the typical area, particularly for small children. So we do see Kawasaki disease generally starting at 2 months of age. So if your baby comes in, one of the first things you want to take off their diaper and see if they have a rash in this area, and it can be a fairly severe rash. And it might only occur in that area, but it can also occur throughout the entire body just like this. It's just accentuated in the diaper area. And if there's vesicles, bullae, it's most likely not Kawasaki disease. Here's another picture of the rash. It can occur over the entire body. And surprisingly, you can have a rash like this, and I have heard doctors in the emergency room walk in and there's a rash like this. They walk out, come back an hour later, and the rash has disappeared. So if they have any rash, we call it evanescent rash, one that comes and goes, it can disappear. So you really have to rely quite a bit on the parent history in making the diagnosis. So if you go in and there's no rash at that time, but the parents say, my child had this rash, then you've got to believe them and include that as one of the criteria for making the diagnosis of Kawasaki disease. Okay, so here's another picture of the rash, and here's what, this is kind of severe, some of the extremity findings, and these are later findings. So when patients come in at about 4 or 5 days, 6 days of fever, they probably won't have the feeling, the peeling. But you do have to be really attentive. You look at a baby and they all have like chubby fingers, but if the parents tell you, hey, his fingers look a little bit puffy, even though it doesn't look like that to you, to me, the parents know better than you. They've seen the child before. That is one of the criteria for Kawasaki disease, because sometimes it's really hard to document or by your own observation see that there's swelling. So you have to take the parent's history. That's really very, very important in making the diagnosis. And some of these changes can be pretty subtle. So here, these are a little bit more subtle, but you see on the soles of this child's feet, there's some redness and a little bit of swelling. He's kind of starting on his toes to have a little bit of peeling. So this is probably about 8 or 9 days after the onset of fever. Kawasaki disease was initially called mucocutaneous lymph node disease. But even today, when kids come in with these swollen lymph nodes, often the physician's not thinking about Kawasaki disease. I personally think that if a child comes in with 5 or 6 days of fever and has a swollen lymph node, then you need to diagnose Kawasaki disease and consider it's Kawasaki disease until proven otherwise. That you don't immediately start on a pathway to treat cervical adenitis. And this is typically what can happen is that the child will have swelling, especially babies, because they don't have huge necks, that they're going to have swelling in this area. It's not the mumps, it's a swollen lymph node. Sometimes they come in like this, and the evaluator will order an ultrasound or a CT, and I can tell you they're looking for abscess formation that 90 to 95% of the time, the CT just shows swelling or enlargement of the lymph node with no abscess and no fluid collection. So sometimes they come in and they have all these other symptoms, but this is a chart of the other types of symptoms they have. So the kids are usually irritable. So if you see a classic Kawasaki child who has 4 or 5 of the clinical criteria has 5 or 6 days of fever, they're like screaming little banshees, and they're not going to be really cooperative in the emergency room. But, you know, how many people are going to be really not irritable after you've been up sleepless for 5 or 6 days with a high fever, and your parents are trying to treat you with Motrin, Tylenol, whatever, and it's just not working? So most of them are irritable, but the older kids, I have seen notes written, well, this 7-year-old, he can't have Kawasaki disease because he or she is not irritable. But for some reason, the older kids come in and they're not quite as irritable. But I have mothers tell me, this is not my child. And indeed, a few weeks later after they've been treated, this really screaming, nasty 4 or 5-year-old is just an angel when you see them in clinic. So their personality changes substantially. Many of them have vomiting because they're sick. They have fever. Some of them have a cough. Obviously, their appetite's down. A few of them have gastrointestinal symptoms. They haven't been drinking well. They're almost always dehydrated. A lot of them do have some joint pain along with it. It's usually not joint swelling, but just some generalized arthritis. And there's occasionally a child who won't walk because he has some knee pain. So that's just to say that they can have other symptoms, and you still need to think about Kawasaki disease, even though they have these nebulous type symptoms. And I mentioned a little bit about coexisting infection. And again, the general theory is that there was an infection that triggers an inflammatory response. So they can come in and they can have positive tests for certain types of infection. But, you know, you really have to take it in context. So if you have a cold and you're positive for a respiratory virus, you're not going to have that rash. You're not going to have the conjunctivitis. You're certainly not going to have the swelling of the extremities. So you have to take that data in context with, does it fit the clinical picture that the child is presenting with? So presence of a coexisting respiratory infection or positive viral test or even a positive strep test does not rule out Kawasaki disease. So I talked about what we call complete Kawasaki disease, and that's where you have the fever plus 4 of the clinical symptoms. The American Heart Association guidelines also say that you can make the diagnosis with fewer than 4 of the clinical criteria. So if a child has 7 days of fever and 2 or 3 criteria, you need to think about Kawasaki disease. Particularly in infants, infants will often come in with less than 6 months. They've had persistent fever. They have 7 days of fever. You can't find anything else. They don't really have any signs of Kawasaki disease, but you can make that diagnosis. And part of it is based on laboratory data. So you get the CRP, the C-reactive protein, and if that's elevated, and in addition they have 3 of these criteria, either elevated liver enzymes, a reduced albumin, a white count that's 15,000, anemia for age, platelets, so usually they come in at 8 or 9 days, maybe 10 days. Usually their platelet count is elevated over 450,000. And often the kids will have a lot of white blood cells in their urine. So a child comes in with fever, he's got maybe a rash, then someone gets a urinalysis, they have a lot of white cells in their urine, and it's like, oh, it's a urinary tract infection. It's like, well, you don't really get a rash from a urinary tract infection. You don't get conjunctivitis from a urinary tract infection. So you really have to think about everything in context. The sickest children who come in initially have something called Kawasaki shock syndrome, and we actually have a patient in the hospital right now who has Kawasaki shock syndrome. And that's a subgroup of patients, and they have really vascular instability and blood pressure lability. So they'll come in and they'll be hypotensive, and you give them a lot of fluids to try to get their blood pressure up, and it doesn't really help. And they all seem to need pressors to maintain their blood pressure. So these patients are often admitted to the intensive care unit, but they're often delayed diagnosis for Kawasaki disease because they come in and they only have 1 or 2 of the clinical criteria in addition to the fever. They're also usually older than 5 years, so you get back to that age thing. People aren't thinking Kawasaki disease usually for those patients because they could even be a teenager. So finally, why do we have this blood pressure instability, and then an echo is often ordered, not to see if a patient has Kawasaki disease, but to look at heart function, and maybe that's related and causing the low blood pressure. So here's an interesting case. So we had an 11-year-old young lady, and I'm taking these quotes from the ICU note. She was previously healthy. She had 6-day history of fever. She had neck and throat pain. She had, in red, right-sided cervical adenitis. She was getting antibiotics in her PMD's office for about 4 days, but didn't seem to help with anything. She had conjunctival injection. So already, right here, we have 2 criteria for Kawasaki disease. She was hypotensive. So here's a summary of the things that she had, and here's her laboratory study. So that fits with Kawasaki disease. That's one of the lab criteria. That's one of the lab criteria, and that's one of the really high CRP. So they really weren't thinking so much about Kawasaki disease. Why? Because she was 11 years old. So a day or two later, they were treating her with antibiotics, with vasoactive pressors for blood pressure management. Eventually, they did get an echocardiogram. So the echocardiogram, and I told everybody I had to show at least, is there any way to get these lights down a little bit? So for those who do not look at echoes frequently, this is a cross-section, two-dimensional image of the heart at the level of the valves. And this is the aorta. So everyone knows that the aorta is the larger blood vessel that leaves the heart along with the pulmonary artery. So you can imagine that the coronary artery is coming off the aorta. I believe this is the right coronary artery starting to come off. That's about the size it should be. This is the size of the left coronary artery. So it's huge. It's probably about 4 or 5 times what it should be. So this is, by echocardiogram, what we call an aneurysm. So it's an outpouching and a big sac that grows on the artery, secondary to the Kawasaki disease. And this is this child, 11-year-old, later got an angiogram, and it's a little bit easier to see how much this artery is dilated. So this is an injection into that coronary artery, and you can see this aneurysm. And even this artery here, there's the aneurysm, and then distal to it, it's still a little bit enlarged. It should at this point, it probably should be about that size. So there's diffuse enlargement of her coronary artery with a very proximal aneurysm right near its origin from the aorta. So this is just an example of an older child who comes in, doesn't quite have the classic features. She's older. They're not really thinking about Kawasaki disease, but indeed she does have Kawasaki disease. So I hope I've emphasized the age thing enough. So let's talk about the treatment. So when we do get the diagnosis, the treatment is intravenous immunoglobulin. And there have been clinical studies that show that it works at a dose of 2 grams per kilo IV. And we know from the clinical trials that if you give it within 10 days of the onset of fever, that it does have a positive effect. We're not sure if they come in for longer fever than 10 days, but still, if they still have persistent inflammation after 10 days, like persistent fever, or if they have a positive echo or signs of systemic inflammation, then we would still give the IVIG. When you give the IVIG, about 20% of the patients have coronary artery inflammation, and at least in our series, it's 7 or 8% that have aneurysms, and 4% have what we call huge aneurysms, depending on our measurement of the diameter of the aneurysm. And those patients certainly need anticoagulation. So also in the initial phase, we give anti-inflammatory doses of aspirin, and there's absolutely no evidence that shows that aspirin helps with Kawasaki disease. The problem was in the 1960s, the only treatment they had was aspirin. So we've been giving aspirin for about 50 years for Kawasaki disease, and ethically it would be hard to do any clinical trial saying, well, let's compare an aspirin group versus a non-aspirin group. So we're always going to be stuck with the aspirin, even though I think most Kawasaki specialists think that it really doesn't do that much. But what the American Heart Association guidelines have recommended is that we used to use a dose of 80 to 100 milligrams per kilo. And the new recommendations now say, well, you can use a moderate dose. So they came down a little bit. Because these kids, if they are on aspirin, especially high dose for a long time, they're going to get sick from the aspirin. They'll start vomiting, they'll get liver toxicity. So we don't want to give them a lot of aspirin. So we're working right now on a clinical standard work pathway, and it will include this moderate dose as opposed to the high dose that we used to use as 80 to 100 milligrams. So we give that into their afebrile or for about 48 hours. Some people really like to give it for a prolonged time, but we're not going to have that in our pathway because, in effect, I don't really believe that the aspirin at high doses does much of anything. However, aspirin at low dose does have an antiplatelet effect. And I remember I told you we want to prevent clots from those dilated, inflamed coronary arteries. So that once they come off the high or moderate dose aspirin, then they're on low dose aspirin. So this is a maximum of 81 milligrams, which is one baby aspirin a day. That's similar to someone my age taking it to prevent clots in coronary arteries that might have problems with other type of coronary problems. Important, it seems to be a generic in our hospital. The patients are told that you can take ibuprofen for fever. However, ibuprofen interferes with aspirin. It prevents its antiplatelet action. So any child with Kawasaki disease should not be, that's double negative, but they should not be on ibuprofen. And it shouldn't be recommended, and parents shouldn't be told at discharge that ibuprofen is okay. So I put here some of the important nursing issues. So for the floor nurses who are administering the IVIG, here's some of the important things. I have discovered, I think this was fixed a year or two ago. I haven't seen it happen recently, but the IVIG infusion is supposed to go over a 12-hour period. I have seen the nurses receive the wrong rate sheet from the pharmacy. Again, this hasn't happened recently, but in the past that's happened. So you need to closely check your rate sheet and make sure it's a Kawasaki-specific rate sheet for IVIG and that it should go over a 12-hour period. Now, sometimes the kids get hypotension, and you need to stop it until their blood pressure recovers, so it could take longer, but it certainly shouldn't go in much faster. So these kids, part of the problem is that they have this vascular instability. Their heart function could be affected, and you don't want to give them a big volume overload with the gamma globulin. So you want it to go in very slowly. So again, don't give it too fast because of possibility of causing hypotension or some other reaction. Just to tell you, it's okay to go slow. Back in the 1980s, the initial studies had IVIG given over a 4-day period with 4 separate doses. So it's okay to slow it down. Sometimes it takes as much as 24 hours if the patient's not stable. However, once the diagnosis is made and the order is in, we need to give it as soon as possible. So there shouldn't be delays by pharmacy, and there shouldn't be delays by nursing. The nurses, as soon as the order's in, the nurse needs to call the pharmacy and get it up and start it as quickly as possible. And there's a lot of reasons for that. I mean, for one thing, there's a big parent expectation. Okay, my child has Kawasaki's, my child needs gamma globulin, and they don't really appreciate if there's a 4 or 5 hour wait in initiating the therapy. The other important issue that I find for nursing is that the nurses are really good at recording time of initiation. And my understanding is that here, that IVIG is treated as a medication and not as a blood product. It actually is a blood product, so it's kind of odd that we do it that way, and we're working on that in the clinical standard pathway. So you put in when you give a medication, but you don't always record, my understanding is that nurses don't always record when the medication is finished. So if you give a antibiotic, you say, here's when I gave it, but you don't say when it's done. But it's very, very important, and I'll tell you why in a moment, that not only do you record the time of initiation, but when that you need to record the completion time. That's very important to us in following the Kawasaki patients. So I'd like to point out that these patients, when they come in, they have 5 to 7 days of fever at home. So the parents have been dealing with this sick child with fever who's irritable, many sleepless nights. There's been most likely multiple physician and prolonged ER visits. It's a mysterious disease. They've tried different diagnoses. Sometimes they've been on antibiotics. It's uncertain outcome. It's like, hello, this could affect my child's heart. Like, that's a stressor in itself. Then we give the IVIG with the constant vital sign assessments that are necessary. And that's part of the reason that they expect prompt therapy, but that gives a lot of stress to the parent and to the child. So one of the things that we did, it's interesting here at Seattle Children's, is that Rita Mangione-Smith's group in general pediatrics, they have a program where every child who is admitted, they try to get them to complete a survey on the child's functioning a few weeks before admission, the child's functioning at admission, and their child's functioning 6 weeks later. So I looked, and in fact, we had this data on the Kawasaki patients. How much stress and how much dysfunction do these childs encounter? And how do we do this? Well, we had to compare it with other diseases. So there is no other disease like Kawasaki disease, because how many diseases come for 4 to 5 weeks and then seem to go away? But we do have other acute diseases, and one of them is pneumonia. And we have other chronic diseases that patients get admitted for, and those are different cancer diagnoses. So what we did was we took these health-related quality of life scores, and we had about, we ended up having about 80 or 90 Kawasaki patients who had filled this out. So here are the baseline scores in white, admission scores, and then in light blue are the follow-up scores. But the most important point is this is pneumonia, and the children do have a decrease in function. Here's cancer. They do have a decrease in function, but you can see there's a significantly more decrease in function in the Kawasaki patients at admission, and one can expect that. The next thing we need to do is follow up, because a lot of parents tell me that they themselves, they feel that Kawasaki disease was like some sort of post-traumatic stress syndrome, and like even a year later that they still have nightmares about this whole situation with it being stressful, not knowing exactly what was going on, and they still think about it a lot, and it probably affects their function. So one of our fellows, Dr. Curtado, she did this analysis, and this is going to be published in the Journal of Pediatrics shortly. Okay, let's go back to some of the things that nurses can help us out. So some of the discharge instructions, because parents often will go home and they could be a little bit confused. They call us a lot for things that are very common in Kawasaki disease. So I think if we educate them before they leave the hospital, that will allay quite a bit of their anxiety. For one thing, their behavior will not return to normal for at least a 4 to 6 week period. They're going to be sleepless, they're going to be cranky, their appetite is going to be down. So they're going to have all those things. We need to warn them. Their hands and their feet, to expect skin peeling. That's typical for Kawasaki disease. Expect it. Don't worry about it. It's nothing special. It doesn't mean that the Kawasaki's is coming back. It's just part of the natural course of the disease. You can treat it with emollients, creams, whatever, but don't freak out because your child starts having this. Another thing is I find that the Kawasaki kids, their skin is really sensitive for about a 6 month to 1 year period after the Kawasaki disease. So today I saw a kid in clinic, and it's a pale child. He's got peeling all over, and the family tells me they're going to Hawaii in a month from now, and I'm just like, oh my God, you guys, make sure you use tons of sunscreen because his skin is going to be super sensitive when he's exposed to that sun. So those are all important things to stress to the parents. Also the instruction, everybody should have a thermometer. Make sure they have a thermometer at home. And if their child feels hot at all, take the temperature, because we are looking for what we call refractory Kawasaki disease that doesn't respond to IVIG as we would hope. Part of that is recurrence of temperature greater than 100.4, and that's why they need to have that thermometer. Even if their child is feeling fine and they think everything's going well, and the initial echocardiogram was normal, because we get an echocardiogram on every child at admission and with the initial treatment, even if that's normal, you can still have coronary artery abnormalities that can develop over a 6-week period after the initial Kawasaki disease. So they need to come in. Do not miss that appointment. It should be in about 2-week time frame after their discharge. And there are many children who come in who had a normal echocardiogram, and they come in at 2 weeks and their echo is normal, show coronary dilation, even aneurysm. Some of them we've had to admit to start anticoagulation. The other thing you need to tell them, and there's a lot of confusion about this, is that when you get IVIG, what happens, it suppresses your immune system. So if you get an important immunization, like measles, mumps, rubella, or the varicella, it's not going to work. So if you get that immunization, say a month or two after your child got IVIG, you think, okay, my child's immunized for mumps, or even most importantly, measles. But in fact, they did not have an effective immunization. So for that reason, the instruction should be that they need to wait an 11-month period to get that immunization. And the reason for that is we know that the immunization will be more effective when the IVIG is gone and no longer suppressing the immune system. So it's not the fact that it's dangerous, except that you could be going with a misconception that your child is immunized. They can get the influenza vaccine because a lot of the because it is a live vaccine, but it's not a long-standing immunity that it gives. So you try to limit how much chance you can have of getting influenza. But I prefer that it's not given at discharge, because sometimes the kids get the immunization and they get a fever from that. And then, well, okay, is it a fever from the immunization, or is it a fever because they're refractory to IVIG? Also, very important, and sometimes parents are confused about that. Make sure, number one, they're going to go home with aspirin as an antiplatelet. Make sure the dose formulation is reasonable. So I've had parents come back to clinic and we have to give 1/5 of an aspirin tablet. And it's like, how do you do that? And they're like, shrug, well, we try our best. Should be a half tablet, maybe a quarter tablet if it's a very small baby, or a full tablet. So it needs to be rounded. So if you see an order and it comes out to like 32 milligrams, which would be 1/3 of a tablet, you should, or 3/8 of a tablet, it's best to call the house staff and say, hey, this really isn't a reasonable dose. Can we figure out something that's easier for the parents? The other thing is they need to continue that aspirin until they see the cardiologist and follow up about 2 weeks later. I have had sometimes, for some reason, that the discharging docs think the patient's going to be seen in 2 weeks, but in fact, something gets screwed up with their appointment and they come in 3 weeks. They come in a clinic. How's it going with your aspirin? Oh, well, we ran out 2 weeks ago. They gave us a prescription for 2 weeks. They need to take the aspirin until they see us in clinic. That's probably the most important thing that a parent can do for their child with Kawasaki disease, because that's a preventative, and it prevents the most dire consequences of Kawasaki disease, which are thrombosis in the coronary arteries. So it's really important that the nurses stress that. And, aspirin, baby aspirin's no big deal. We give them a prescription, but they can just go to the drugstore if the over-the-counter baby aspirin is the same as the aspirin that we prescribe for them. So if tell them if you run out of aspirin, there's a problem with prescription, just go get the over-counter and baby aspirin. It's 81 milligrams, and give them that. Again, I said about ibuprofen, and again, it's constant. I see on the discharge sheet medications, ibuprofen if fever or pain. No ibuprofen. It's an American Heart Association recommendation, and there's been studies in the New England Journal that show that ibuprofen interferes with the antiplatelet action of aspirin. So we don't want them to get that. Okay, so let's talk a little bit about refractory Kawasaki disease. So that means, and this is why we really need you to record carefully the time when the IVIG infusion is completed. The American Heart Association recommendations define refractory as fever that occurs greater than 36 hours after completing the IVIG. So if we don't have a definite, sometimes I have to backtrack. Okay, it started at a certain time, 12 hours, but then for all I know, it took 14 or 15 hours, right? So we really need to know when it was done, because the definition of refractory IVIG is totally dependent on the time that the infusion is completed. The other thing about refractory, so a patient 36 hours, at 36.5 hours, patient has a temperature of 38.1. That might not be refractory. So you want to see at least 2 or 3 spikes at a reasonable, at least well over 38. And I will often ask the hospitalist or the house staff to get a CRP, because another sign of refractory to IVIG is that their CRP either doesn't come down or it goes back up. So that's also important. And the reason that defining refractory and treating refractory IVIG is important is that those patients have an extremely high risk of developing coronary artery disease, either severe dilation or aneurysm. So they're if they don't respond initially over that 36 hours to IVIG, they're put in a very high risk category. This is just a more clear picture of what the aneurysm can, and this can happen in patients who aren't refractory, but it does happen probably 40% of the time in refractory patients. And this is actually a 6-month-old, so you can imagine that you're 6 months old and you already have substantial coronary artery disease. And you can see this very large saccular type aneurysm. And what happens with these aneurysms is at this point, and even more at this point, there can be stenoses develop. And then a child could be at risk for a myocardial infarction. Later on, if a child has Kawasaki disease with inflammation, there could be scarring in the coronary artery. And here you can see the intimal hypertrophy. And this causes narrowing. So if the artery, the blood flow is going this way, then this is an area that there's limitations in blood flow, and that comes more symptomatic when they're older and they do some exercise because they don't have enough blood flow for their heart to maintain that oxygen consumption that they need during exercise. So again, refractory IVIG, document the fever after 36 hours. So what do we do if we diagnose them with refractory IVIG? So right now there's 2 choices. There's a second round of IVIG, or there's infliximab or Remicade, which is an anti-inflammatory monoclonal antibody. Neither is absolutely proven effective because there's been really no placebo-controlled trial, no large trial, comparing a second dose of IVIG with placebo. But one of the things is some centers use a second dose of IVIG, some centers use Remicade and infliximab. Which one's better? So the group in San Diego, Jane Burns' group, they developed a consortium of which we're part of, and we're doing a large multi-center study to randomize patients either to IVIG or to infliximab. Infliximab infusion's a little bit easier. It's over 2 hours instead of the 10 to 12 hours for the IVIG in the second dose. Infliximab does hang around for quite a while, probably about 6 weeks in the body. So, and it has been known to reduce your response to certain types of infection. So there are some side effects. We also get side effects with the IVIG. So this is a really important study, and it's kind of strange that I'm talking about this today because we enrolled our first patient here at Seattle Children's this morning and randomized that patient. But so far in the national consortium, this only got started about September. This would be the sixth patient enrolled, and there's a goal of 250, which is going to be pretty tough because only about 20 to 30% of the patients with Kawasaki disease are refractory. So just a lot of people think you get Kawasaki disease, you get your IVIG, you go home, you're fine. But many of the children do get lifelong heart disease because of those aneurysms. And what does that mean? They'll often be restricted to activity. Some of them are on drugs like enoxaparin or warfarin. Enoxaparin, the parents for the small babies will have to give them 2 daily injections of this anticoagulation. That's not fun, giving your small baby 2 injections. They get bruised all over. The older kids can be on enoxaparin or on warfarin. They can't participate in contact sports. If they do have significant aneurysms and stenoses, we have to limit their participation in sports. It's been known, at least in Japanese series, that the age of death is earlier than the general population. So Kawasaki disease, if you get the coronary artery disease with it, is a pretty substantial and important disease, and it affects children's lives. So we have a lot of challenges. We need to understand and define the risk factors. The diagnosis is still difficult, so we need some sort of biomarker. So when they come in the emergency room, we can do a unique biomarker instead of looking at these nebulous clinical and laboratory criteria, a biomarker that you can take a blood test and say, yes, you have Kawasaki's, or no, you don't have it. As I said, IVIG, 20 to 30% are refractory or resistant to IVIG, and they don't get an appropriate therapeutic response. When they do get aneurysms, we don't really have good methods of preventing or healing the aneurysm. And the anticoagulation therapies aren't great. I told you about enoxaparin, Lovenox, 2 daily injections in a small baby. And we do that because warfarin is, it's unstable in small babies. So your target is a certain INR, usually around 2 to 3. We can't seem to keep it in that range when they're on warfarin. And they're getting multiple blood sticks to test for their INR. There are a lot of new anticoagulants on the marker. There's specific thrombin 10 inhibitors, and we are going to participate in some clinical trials to look at new anticoagulation medications in Kawasaki disease. As far as the risk, we think, because I told you about the incidence differences in the Asian and Caucasian population, part of the risk we believe is genetic. So we have banked DNA in about 800 patients, and we have about 450 trios, which means not only do we have the patient's DNA, but we have both parents. So we can look at the rate of gene transmission between the parents and the children with Kawasaki disease to see if there's increased transmission of some mutations to the children with Kawasaki disease. And indeed, we have found that to have happened. And there's something called the Fc gamma receptors, which are these receptors on inflammatory cells, and gamma globulin binds to them. And they seem to play an important role, not only in the susceptibility to Kawasaki disease, but in the treatment response by IVIG. So everyone's been focusing, in the world has been focusing primarily on the genetic factors. We've done that ourselves. Other centers have done that. But could there also be some sort of environmental risk, something in the environment? Is it just genetics that's responsible for the higher Asian incidence? So it's interesting, I thought about what's different in Asia than the United States. What do they do differently? So one of the things I thought about was, well, is there diet? Because in the 1990s, the FDA said the Asian diet is wonderful for cardiovascular health. Oh, they had absolutely no data showing that. And they said one of the important things in the Asian diet is soy. Soy is really important in keeping good cardiovascular health. So since the late 1990s, there's been multiple studies in adults showing that's absolutely not true. There's no protective effect of soy for cardiovascular disease. But that's still hanging on, and people get this mentality, oh, soy's really good, tofu's good. However, in 2008, the American Academy of Pediatrics Committee on Nutrition issued a statement because they were worried about what we call isoflavones, which are these estrogen-like compounds in soy. So under their communication, they said there's limited indication for the soy formula in infants. So basically, infants should only get a soy formula if they had a specific type of lactose deficiency, because they were worried about estrogen and how it affected sexual development, because these compounds have many estrogen-like qualities. So I thought about this, and I posed a hypothesis that was published in the journal Pediatric Research. And here's a little soybean in our picture here. And is it related to Kawasaki disease? And remember, I told you about these Fc gamma receptors. So the components in soy actually affect the action of these Fc gamma receptors, which seem to have an important role in Kawasaki disease. So this was a theory, and part of it was based on these Fc gamma receptors, because this component in soy called genistein, which is an isoflavone, estrogen-like compound, actually blocks the action, the molecular action of these Fc gamma receptors. And it can just throw the whole thing, the control of inflammation, out of balance. So could soy be doing this? Could the reason that Asian populations have more Kawasaki disease is because they're at high risk because they eat so much soy? So I didn't have really good data by myself, and I went to the literature and I extracted two epidemiological studies. One looked at soy consumption in populations, 3 different ethnic populations in Hawaii. So there was a Japanese, there was a Native Hawaiian, and there was a Caucasian. So Japanese eat substantially more soy than Native Hawaiians, who eat substantially more soy than Caucasians. So I plotted in Hawaii. They actually kept good records for each of these individual ethnic groups on Kawasaki disease. So I plotted the incidence of Kawasaki disease in each of those groups, and there's almost a direct correlation between soy consumption in each of these individual ethnic groups. This is for children under 5. This is for children older than 5. And even for both age groups, there was a relationship between soy consumption and Kawasaki disease. Well, that's interesting. It's an association. It kind of supports some hypothesis that I said that the isoflavones play a role in Kawasaki disease. But we need a little bit better data. So we went back to our patients, and with the help of nutritionists at Fred Hutch, we did an analysis. We had our parents fill out nutritional surveys, and we didn't really tell them why we were doing this, so we embedded all sorts of foods, fish, tofu, all sorts of other miso soup, that sort of thing. And it turned out that we had 200 Kawasaki patients. We had age-matched control groups that we extracted for children who were seen in cardiology clinic but didn't really have any significant disease, a lot of murmurs or my chest hurts, things like that, that turned out to not have cardiovascular disease. So we used those as controls. And here's what happened. Here's the total isoflavone intake, which is that important component in soy. And these are the controls, and these are the cases. And you can see that the distribution, the average of the soy and isoflavone consumption is much higher in the patients with Kawasaki disease than the controls. So then we said, okay, well, maybe there's so many Asians and that's affecting it. So we broke it off and we looked at Caucasians, and we found the same relationship in Caucasians. And here's the relationship in Asians. So it looked like if you were in the highest quartile, so we took the quantiles and we looked at the very high soy consumers, And we found that if you're a high soy consumer, now this is a child, for instance, who's on soy formula as his only formula, or there are a lot of kids who really like soy milk, even a 2 or 3-year-old just drinks a lot of soy milk, or they eat a lot of tofu, they love tofu, that if you're one of those children, that your risk, the odds ratio of you developing Kawasaki disease is 2.5, which is a substantial and significant risk. So I'm not saying that soy causes Kawasaki disease, but the way to think about it is smoking is a risk factor for heart disease or cancer, but tremendous amount of soy consumption is a risk for Kawasaki disease. And it doesn't matter if you're Asian. In fact, if you're Asian, it's even a magnified risk. It's not just that for some reason the Asian population is more sensitive to the inflammatory components that are in soy. So I'm not sure how many of the nurses on the floor have been here for a while, but we have just completed and have done our data analysis in the etanercept study. And I told you about this a little bit. This is Enbrel, and it's an anti-tumor necrosis factor drug. It's used in multiple populations, especially with rheumatoid arthritis, sometimes with Crohn's disease. It's been around for about 25 years. It has a very potent anti-inflammatory effect, similar to Remicade, but it works in a different mechanism than Remicade. And you give it by an injection. So several years ago, we did a pilot study which showed that etanercept might be effective in preventing IVIG resistance. So that it actually, if you give it along with the IVIG, it might prevent those patients needing a second line therapy, such as a second dose of IVIG or Remicade. So here's a mechanism of etanercept, and if you watch TV ever, you're going to see Phil Mickelson on commercials advertising it for psoriasis. But the mechanism is a little bit different from Remicade because Remicade's a monoclonal antibody. Etanercept is a receptor analog. It binds the TNF, which is an inflammatory protein, which in some ways participates in the inflammation in Kawasaki disease. So it's a totally different mechanism than Remicade. We did a multi-center trial. We completed it, over 200 patients in a placebo-controlled with about 100 in each arm, those who received placebo, those who did not. We're presenting the results next week at the American Heart Association. And remember I told you about differences in ethnic response? The IVIG response rate is really, really high in the Asian population. It's like 90%. So they respond really well and don't have that much only 10% refractory rate. However, and that's also a similar response rate in Hispanics. But in white non-Hispanics and African Americans, IVIG does not work as well. And because of that, I believe that etanercept was able to reduce the refractory rate in those populations. So it's really important. It's kind of personalized medicine. So if you come in and you have certain ethnic background, perhaps you should get etanercept. And if you're Asian background, I don't really think that etanercept is going to do much for you. Here's some of my investigators in the past, some of our current faculty, Aaron Olson, Nadine Schwetter. It was our first cardiology fellow who's now in New York and participating in some of our trials. Here's Kristen Sexton, who is now in Texas, also participating in our trials. And Dr. Naguib Dado is an important contributor who is at St. Justine Hospital, Children's Hospital in Montreal.